So now we will discuss the station of uterine perforation. This is a very easy station, but commonly it comes in exam. Here is the scenario that you are the fourth year resident in the gynae theater today and you are performing routine laparoscopic tubal sterilization for a 39-year-old lady. Your first year resident was assisting you and he instrumented the uterus for you to help in manipulating during the laparoscopy. Okay. And your consultant has been called from the coffee room by the scrub nurse. Following the successful pneumoperitoneum, when you entered your camera, a copy of the first laparoscopic view is attached. So this is the laparoscopic view. This is the uterus, and this trocar is coming out through the uterus. Your first year resident has used the trocar for manipulating the uterus, for elevating the uterus. So he has perforated the fundus of the uterus with the trocar. So while you enter the camera in the abdomen, you see this view. And your task now is that assess and explain the findings in context with the case. What are your immediate action, formulate and justify an intraoperative and post-operative management plan? And how will you take the things forward with your first year resident and answer the examiner question? So this is your task. Okay. Now, how will you do? This is the flow sheet for the management of the uterine perforation, but how we will start the discussion. So the diagnosis here is that it is a laparoscopic image that is showing uterine perforation with the trocar. And what will be your immediate action? First immediate action is communication and resuscitation. Communication means call for help. That you will reassure your first year resident that a complication has occurred and you will inform the anesthetist that surgery time will be prolonged and continue to monitor the vital signs and start the antibiotics after excluding the drug allergy. Then you will inform the theater team and the circulating nurse and you will insert the Foley's catheter and you may need extra instruments for exploration. Inform the consultant. Other specialties, they should be involved if other organs are involved. For example, you can involve the urologist, general surgeon, or the vascular surgeon if there is suspicion of injury to the bladder, gut, or the great vessels. If you will inform the blood bank to prepare the blood and the blood products if there is no objection for the blood transfusion. And in surgeries other than laparoscopy where the patient is under regional anesthesia, in this case, the patient will be under general anesthesia. But if the patient is under regional anesthesia, then you will inform the patient in a non-frightening way that we have a complication, but we are working on it, and you will expect more people to join us in the surgery. And but here the case is different. The patient will be under general anesthesia, so patient will be debriefed in the post-operative period. But if you have come across a case where the surgery is being done under spinal anesthesia, then you will also inform the patient in a non-frightening way. Then how will you formulate and justify an ongoing management plan? You will insert the urinary catheter if it is not done already, and you will monitor the urine output. Along with this, you will confirm the site, size, and the number of uterine perforation. Okay. Trocar, it should not be removed until the blood is ready and the consultant has arrived. Removal at this point, it can cause more trauma and it can increase the perforation size and the amount of the bleeding. Okay. So once the consultant has arrived and the blood is in hand, then you will remove the trocar. And you will remove the trocar gently under VN. If the size of the perforation is small, that is less than 5 millimeter, and there is no bleeding, then it can be managed conservatively with observation and antibiotics only. There is no need for intervention. But if the size of the perforation is large means that it is more than 5 millimeter and there is bleeding, then you will check whether the patient is stable or not. If the patient is stable, then repair can be done through laparoscopy if the expertise are available. But if the patient is not stable, then laparotomy should be done immediately. And the most important point, which many candidates they forget to mention, that after repair of the perforation, you will continue the sterilization procedure after stabilizing the patient and repair of the perforation. Okay. This laparoscopy was being done for tubal sterilization, for tubal ligation. So after the perforation and the patient is stable, then you will also do vaginal exploration to exclude any vaginal or cervical lacerations, and you will confirm the instrument and the swab count. Okay. So in this way you will manage. Then next, what you will do, what is the post-operative care plan for her? Plan of management during the hospital stay, you will shift her to the high dependency unit. You will continue to monitor her. Intake output record will be maintained. Proper analgesia will be given. VT risk assessment will be done. You will debrief the patient. Duty of control will be performed. Documentation will be done. Incident reporting will be done. And discharge plan will be discussed with the patient. And we will write letter to the GP, and red flag signs will be explained to the patient. Okay. And we will also tell her that after sterilization, effective contraception will be used till the next period. Okay. And the failure rate of sterilization is 1 out of 200. At the time of discharge, we will also explain the red flag signs, because like if she is having fever, vomiting, abdominal pain, or distension, that she will come back immediately. Then what is reflective practice? Reflective practice is that you will sensitively talk to your first year resident. First year resident, he will be worried, he will be demoralized that why perforation has occurred. So it is very essential to talk to the first year resident, and we will provide him constructive feedback. Okay. And this feedback, it should be in a non-blaming manner. Okay. And we will tell her that good point is that it was discovered intraoperatively and it has been repaired, and we learn from such complications. And we will explore what went wrong and why he has used the trocar instead of uterine manipulator. Okay. And if there was any form of miscommunication with the nursing staff, and we will provide him with support in his ongoing training, and we will help to fill the incident report, and we will complete the form B and reflective practice. ओके. सो ये फॉर्म तो हम यहाँ पे यूज नहीं करते, लेकिन हमें जो है वो ये पता होना चाहिए कि हमने जो है उसको रिफ्लेक्टिव प्रैक्टिस जो है उसको हमने उसके साथ डिस्कस करना है सेंसिटिवली, और उससे पूछना है कि व्हाई ही हैज यूज्ड द ट्रोकार इंस्टेड ऑफ यूट्राइन मैनिपुलेटर, वेदर देयर वाज एनी मिसकम्युनिकेशन, and we will provide support in his ongoing training. Okay. And then we will follow all the steps of the clinical governance. जब भी कोई पोस्ट ऑपरेटिव कॉम्प्लिकेशन है तो उसमें आपने 7 days ऑफ क्लिनिकल गवर्नेंस नहीं भूलना. ठीक है. इसमें सबसे पहले जो है वो डॉक्यूमेंटेशन है, देन डी ब्रीफिंग है, देन डेटिक्स इंसिडेंट रिपोर्टिंग है, ड्यूटी ऑफ कंट्रोल है, देन डिस्कशन, ड्रिल्स एंड डिस्चार्ज. So all these 7 days they will be followed. Okay. And this is all about this station. If you have any question, you can ask. Thank you very much.